hope you all stay awake for the last talk of the day, right? So I've been given the task of talking about rate versus rhythm control therapy for atrial fibrillation. This is the outline of my talk. I'll first talk about the changing face of atrial fibrillation, and some of that data has already been presented, so I'll sort of briefly skim over that. And then I'll look at whether a strategy of rate versus rhythm control really impacts the goals of AF management. And I think that's the sort of most important part of the talk, really. And then discuss why it is that studies to date have failed to show benefit of a rhythm control strategy, and then discuss some novel therapies for treating atrial fibrillation that may show the benefit of maintaining sinus rhythm. So this is, I don't think this, I think this graph has been shown, but in a different presentation, right? So this shows the population of patients with atrial fibrillation in the United States. As you can see, majority of patients who have atrial fibrillation are elderly, particularly in the 7th and 8th decade of their life. Now, if we then impose the US population here, and this was done in 1995, and then transpose that by a decade, you can clearly see the number of people with atrial fibrillation in the United States is going to increase dramatically as the population ages, right? So that's one factor to take home, and that is sort of borne out by this study from the Mayo Clinic. And what this shows, and this is a slide that Dr. Bono showed already as well, and what this shows is the projected number of people with atrial fibrillation in the United States. If the incidence continues to remain at the present rate, 12 million people in the United States will have atrial fibrillation by the year 2050. If the incidence continues to grow, as is predicted from the 1990 to 2000 data, 16 million people in the United States will have atrial fibrillation. So certainly it's going to have a major impact in terms of healthcare utilization. Also, 1 in 4 people have a lifetime risk of developing atrial fibrillation for both men and women who are older than 40 years of age. Again, that data has also been shown. So what are the consequences of atrial fibrillation? And again, a lot of this data has been sort of presented, but this is in a slightly different format. This is data taken from 3 big studies, the Whitehall study, the Regional Heart Study, and Framingham. And what it shows is the relative risk of stroke in patients with atrial fibrillation. As you can see, the risk of stroke increases anywhere from 2-fold to almost 7-fold increased risk of stroke in patients with atrial fibrillation. If we look at mortality, again, the studies on the whole are sort of fairly consistent, showing that the risk of mortality almost doubles if you have atrial fibrillation compared to patients without a history of atrial fibrillation. Besides the morbidity and the mortality, for patients, the major issue is the symptoms that are associated with atrial fibrillation, and that's what they present with, and that's what you're essentially, as a cardiologist or electrophysiologist, you're trying to treat. So the other issues that you have to deal with patients with atrial fibrillation is risk of heart failure, and that could be due to the loss of the atrial kick, it could be due to the loss of AV synchrony, and then the general sense of well-being. They just don't feel well, right? They have these chronic symptoms, and they just tell you that, you know what, I just don't feel well when I'm in atrial fibrillation, really. So those are the things that the patients really present themselves to you with, really, and that you've got to deal with. Obviously, this is an echo showing the presence of a thrombus in the left atrium. Now, what impact, if any, has a rate control or rhythm control strategy had on the goals of AF management? And I hope before discussing that, I think it's important to discuss the major trial in this area, and that's the AFFIRM trial. This is the atrial fibrillation follow-up investigation of rhythm management. It was published in 2002. The hypothesis was it investigated mortality of antiarrhythmic drug therapy to maintain sinus rhythm versus a ventricular rate control alone in the presence of anticoagulation. The primary endpoint of the trial was total mortality. Secondary endpoints included disabling stroke, cost of therapy, and then the quality of life issues as well. And as you all very well know, really there was no significant difference in terms of mortality between a rate and a rhythm control strategy. If anything, if you were randomized to a rhythm control strategy, the p-value was 0.08, you're more likely to have increased mortality if you're randomized to rhythm control as opposed to rate control. Furthermore, the number of hospitalizations was increased in those that were randomized to the rhythm control arm as well. So certainly, this trial would suggest that there's no benefit in maintenance of sinus rhythm. Now, this was a meta-analysis done in 2005, and the reason I put this up is to sort of highlight that a number of other studies have also been done that have looked at rate versus rhythm control. They include the Hot Cafe, I love these names, right? PF, RACE, STAFF, and obviously the largest study by far is the AFFIRM. And what they show clearly here is that there's no benefit of a rhythm control strategy versus a rate control strategy. If anything, and although the confidence intervals straddle one, right, rate control seems to be better in terms of reducing the mortality. And remember, that was one of the goals of AF management, is to try to reduce mortality if we can. So certainly these trials would suggest it doesn't reduce mortality. What about morbidity and particularly the stroke? Again, this is data from the same meta-analysis that was done in 2005, and the results really are very similar. No benefit in terms of maintenance of a rhythm control strategy versus rate control strategy. I think it's important that I emphasize that it's the strategy that was tested, not whether you maintain sinus rhythm. And I'll come back to why that's critical in a few minutes, right? Okay. So here, no improvement in terms of reducing risk of stroke. What about the general sort of improvement in exercise tolerance? This is data taken by Singh in a VA sub-study, and what this shows that there's improvement. If you're in sinus rhythm, there's improvement in your duration of exercise. This is in seconds, at 8 weeks and at 1 year, compared to if you're in atrial fibrillation. So certainly there does seem to be some improvement in exercise tolerance if you maintain sinus rhythm. What about improvement in quality of life? Well, here, again, this is taken from that same study by Singh and colleagues. I think it was done in Minneapolis, right? And what this shows is that if you maintain sinus rhythm, represented by the sort of blue bars, versus atrial fibrillation by the sort of turquoise bars, you seem to have an improvement in physical conditioning, in general health, in vitality, and in social function. But I should emphasize that the data on rate versus rhythm control strategy in terms of quality of life is controversial. Some of the studies have shown benefit and others have not really, so there's no sort of consistency across all the trials. Now, why is it that these studies to date have failed to show benefit of a rhythm control strategy? Well, here, this is one of the reasons, and that's because of the limitations of antiarrhythmic drug therapy. On the top slide, you have atrial fibrillation with an irregular ventricular response and no atrial activity, so that's clearly atrial fibrillation. This is a patient who then gets loaded with sotalol, and then he undergoes DC cardioversion. And what happens immediately after cardioversion, the QT interval prolongs quite dramatically to 620 milliseconds, and within a few beats, they have a short episode of Torsades de Pointes. So this is one of the problems, and this is one of the reasons why the rate versus rhythm control trials have not shown benefit of a rhythm control strategies because of the limitations of antiarrhythmic drugs, particularly the proarrhythmic drugs, but also increase in mortality. And this is sort of highlighted by one of the newer drugs that we have available, and that's dronedarone. This is taken from the Palace trial, and remember this trial was terminated early because of increased mortality in the patients that were randomized to dronedarone. It was thought that dronedarone may actually be a good rate control drug, so this is why really this study was done. And what they found was that individuals that were randomized to dronedarone had a higher risk of stroke, MI, embolism, and cardiovascular death, right, compared to the placebo. And so certainly antiarrhythmic drugs, all the available antiarrhythmic drugs, not only have a risk of proarrhythmia, but may actually increase mortality. And really, that's not a surprise. When you go back to the CAST trial, when we tried flecainide, we know that those patients actually did worse compared to those patients that were randomized to placebo. Another reason why the rate versus rhythm control trials have not shown a benefit of a rhythm control strategy is related to the age of the patients. If you look at AFFIRM, and again, I apologize, this is a very busy slide, but I just wanted to put this up so that you know which are the major trials that have looked at this question. But look at AFFIRM. The average age was nearly 70 years. Even the other ones, it was anywhere sort of from 60 in Hot Cafe to sort of 68 in RACE. So the majority of patients that participated in these trials were sort of older patients. They weren't the young patients who typically have the symptomatic atrial fibrillation. So really applying the results of those trials to the patients certainly that most electrophysiologists see is not appropriate really, okay? The second reason is if you look at the number of patients that were actually in, for example, in AFFIRM, something like 37% of the patients, or actually it was more like 38% of the patients were in atrial fibrillation at 5 years. And 34% were in sinus rhythm in the rate control arm. So really, and this is related to the fact that you were comparing the strategies. You weren't comparing, the analysis was done based on strategy, not based on whether the patients were actually in sinus rhythm. If you did an analysis based on maintenance of sinus rhythm, I bet you the results would be different. And in fact, a sub-study of AFFIRM clearly showed that intention to treat with the endpoint of sinus rhythm did show a benefit, right? So again, the one reason why the trials have not shown any benefit of a rhythm control strategy relates to the limitations of antiarrhythmic drugs, and secondly to the trial design of the trials that have been done so far. Now, talking about trial designs, perhaps we can propose to do new studies. One of the newest studies and a critical study that the results should be available hopefully by end of 2015, 2016 is called the Cabana trial. This is the catheter ablation versus antiarrhythmic drug therapy for atrial fibrillation. Remember, none of these trials so far have compared rate versus rhythm control strategy with catheter-based approach to maintaining sinus rhythm. They're all to do with pharmacologic therapy. This is the first trial that's going to compare a strategy of catheter ablation to show whether it's superior to rate or rhythm control drugs to reducing total mortality, that's the primary endpoint, and decreasing the composite endpoint of total mortality, disabling stroke, serious bleeding, and cardiac arrest in patients with treated or incompletely treated atrial fibrillation. Other secondary endpoints, they're going to look at quality of life, medical costs, resource utilization, as well as cost effectiveness. And this is a major trial. It's going to enroll 3,000 patients, but just last month the study investigators decided that they're going to enroll 2,200 patients because the enrollment has been slower than predicted. And they're going to recruit from 140 centers in North America, Asia, Europe, and Australia, with a randomized 1-to-1 in an unblinded fashion to catheter ablation versus conventional drug therapy, which could either be rate or rhythm control. Patients will be enrolled over 3 years and followed for a minimum of 2 years, and I think the results should be available by the end of 2015, I think. Now, having shown that a rhythm control strategy is not beneficial in terms of mortality or morbidity, are there any new therapies available that will either maintain sinus rhythm and show benefit? Well, certainly there are new molecular targets that can be targeted. But before we think about new sort of molecular targets for atrial fibrillation, and particularly pharmacologic therapy, we have to try to answer these specific questions. As I mentioned earlier, the molecular pathophysiology of atrial fibrillation is very poorly understood. What is it that makes the atria prone to atrial fibrillation? We don't know. Why is it that atrial fibrillation is a progressive clinical condition? Don't know the answer to that either. Where can we intervene to reduce AF susceptibility and remodeling? And particularly here, this dates back to a comment that Dr. Kaba made about reducing atrial fibrosis. And perhaps one of the speakers tomorrow may discuss this as well. And what are the potential implications of atrial-specific therapies regarding the efficacy and adverse effects, and what other targets are on the horizon? Now, I think this is a really sort of cool diagram or figure that illustrates sort of new targets for atrial fibrillation. Obviously, the traditional targets, the traditional targets are the ion channels up here, okay? But there are specific ion channels that occur only in the atrium. So perhaps we should be formulating drugs that target specific ion channels that occur only in the atrium. And one such ion channel is this ion channel called IKUR. And certainly there are drugs that specifically target that ion channel that don't seem to have the pro-arrhythmic effects of some of the other antiarrhythmics that we use currently. Another area there's a lot of investigation going on are drugs that sort of modulate the release of calcium from the sarcoplasmic reticulum, particularly the ryanodine receptor. Also, drugs that target the renin-angiotensin-aldosterone system, and here again it relates to reducing the fibrosis most likely that causes the substrate for atrial fibrillation. And then finally, perhaps we can identify pharmacologic therapy that targets the pulmonary vein ectopic foci that we're also keen on ablating, right? And certainly very little work has been done on this area currently. Now, specifically, drugs that are being looked at that targets some of these pathways. There's class 1 antiarrhythmics called prilosectinib and ranolazine particularly, which was mentioned earlier. Class 3 antiarrhythmics called azimilide, which targets both IKS and IKUR. Tadicimil, nificalant, some of these agents are at least being tested in patients right now to see whether they're better than what we have available in terms of treating atrial fibrillation and maintaining sinus rhythm. In addition, there's a lot of work going on developing drugs that are targeting calcium channel, particularly the ryanodine receptors, because we know that the calcium channel plays an essential role certainly in the remodeling of the atrium that occurs with atrial fibrillation. There are drugs that are being developed that enhance gap junction or improve conduction, atrial electrical conduction, which is typically impaired with disease. There are stretch activated channel blockers being looked at as well as heat shock protein enhancers. And then finally, as I mentioned earlier, is there a role for genotype specific treatment? And as I showed you earlier, for atrial fibrillation as well. So these are all areas where there is a lot of development going on with new pharmacologic agents to maintain sinus rhythm. So in conclusion, current studies have failed to show benefit of a rhythm control strategy due to inadequacies of antiarrhythmic drugs and limitations of drug trial design. Trials with more appropriate endpoints and or better antiarrhythmics are needed. Novel therapies for atrial fibrillation that are more atrial specific or target the underlying mechanisms may show benefits of maintenance of sinus rhythm. And then finally, I just want to acknowledge the study that I presented with the pro-arrhythmic effect was performed by Babar Pervez, who was one of my fellows, and then these collaborators as well as the funding for a lot of our research is provided by the NHLBI as well as the American Heart Association. Thank you.